Um, Thank you. So here's my disclosures. My biggest disclosure is I use Sapien valve in more than 90% of my cases, so we have to take that with a grain of salt. So, there are three TAVR platforms in the United States. I think of them as short frame versus tall frame, short frame being Sapien 3 and tall frame being Evolut or Portico. And in the tall frame, you have Evolut valve with supraannular leaflets or a Portico valve with intraannular leaflets. The Now factors determining the choice of index transcatheter valve are the following, and I'll make a case one by one. So clinical outcomes, I think that's the most important factor that decides which valve we use. Here's Sapien 3 low-risk trial data out to 5 years, no difference in clinical outcomes of death or death stroke or rehospitalization compared with surgery. Here's the Evolut low-risk study outcomes at 5 years, again, at 4 years. Again, if anything, superior outcomes with Evolut versus surgery in low-risk patients. Here's the data from the Portico IDE study, which is Portico valve, but without the current generation, which is Portico, not the Navitor valve, and without the FlexNav delivery system. But even then, out to 2 years, the Portico valve was non-inferior to the commercial valves. Commercial valves in this study included Sapien or Evolut. So in terms of clinical outcomes, I think the currently available valves provide equivalent or similar clinical outcomes. Now, valve performance and hemodynamics. The self-expanding valves offer better hemodynamics than balloon expandable valves. I think we know this, it's established. In the Portico IDE study, the aortic valve gradients and valve areas were similar between Portico and Evolut valve on the left side panel, but they were, they were lower, they were better compared with the Sapien valve. Here's data from Becky Hahn, which again showed that hemodynamics, especially with smaller valves, are better with the Evolut platform compared with the Sapien platform. The SMART trial got a lot of press recently, which showed in small aortic valve annuli, the mean gradients were lower with the Evolut platform compared with Sapien platform, and the valve areas were also better. However, at least so far, what we have seen, the superior hemodynamics of self-expanding valves have not translated into superior clinical outcomes. In SMART trial, it was follow-up out to 1 year with similar outcomes. Opera TAVI registry, again, follow-up out to 1 year with similar outcomes of death, disabling stroke, or heart failure admissions. In fact, in the Portico IDE study, although hemodynamics were better with Portico and Evolut valve, survival at 5 years was better with the Sapien valve compared with Portico and Evolut valve. The hemodynamics have gotten better with the balloon expandable platform with the availability of Sapien 3. But there was a recent analysis presented at London Valves which showed that even with Resilia, the gradients are slightly higher with the Resilia valve compared with the self-expanding platforms. The valve durability. Again, in the Partner 3 Sapien series out to 5 years, there was no difference in bioprosthetic valve failure between Sapien 3 and surgery. Here's data from the Evolut low-risk study out to 4 years, and hemodynamics are better with Evolut compared with the surgical valves. Here's the 10-year follow from the Notion trial, which shows, if anything, less structural valve deterioration with the core valve platform compared with the surgery. So in terms of valve durability, these valves are durable out to as long as the follow-up is available. And we need longer follow-up to see if the differences pan out. Commissural alignment, I think the self-expanding platforms were ahead in this regard, with the commissural alignment. But now with the Sapien X4 system, which is currently in clinical trials, you can also achieve similar result of commissural alignment. The female sex, it got a lot of press with the SMART trial, where 85% of patients were women, and they had superior hemodynamics. But again, there was no difference in clinical outcomes. And then the RHEA randomized trial was presented at ESC, which was a randomized trial of only including women, randomized to TAVR with the Sapien 3 or ultra balloon expandable prosthesis versus surgery. And in this trial, TAVR with Sapien 3 was non-inferior to surgery. And in fact, for the primary endpoint, which was a composite of death, stroke, or rehospitalization, it also met the superiority criteria. In terms of outcomes, we don't see a major difference. But then there are subtle differences in the technique of these procedures and device properties. Deliverability. The Sapien platform is steerable with the retroflex, which helps steer around the arch and also minimizes scraping of the aortic valve as we advance the valve. Portico FlexNav delivery system is very deliverable. It's very flexible and deliverable. I'll show you a case. This is a 90-year-old patient that we treated recently. She had a 19 Magna, so of course we wanted to go with a self-expanding platform for better hemodynamics. But the Evolute valve frame, the nose cone, would just not make it through the valve. It would just hit the valve. And we tried a buddy balloon technique. We did not try a snaring technique, but we tried everything else. So then we quickly switched to a Sapien 3, which crossed easily, and we were able to get this case done. So deliverability can be an issue at times, you know. And then here's another patient we treated a couple years ago, 85-year-old severe AS. She had a small aortic annulus measuring 295 millimeter square or perimeter of 62. So we decided to go with a self-expanding platform for better hemodynamics. Access was not the best. Now on the left-hand panel, this is an Evolute valve. We are advancing. It just won't make it through this calcified segment. We pushed to a very uncomfortable level, and finally we stopped. So we switched on the table to a Portico valve, and here is the Portico valve that makes through the bend, same wire, same catheter, same patient, with no trouble. And when I was preparing these slides, I noted she's actually admitted in the hospital right now. So I have an echo from yesterday where her gradient is 6. Coronary access, I think coronary access is an issue, especially with the tall valve frames. This was analysis that one of our fellows did a few years ago, where we looked at the location of the coronary artery in relation to the valve skirt and the commissures, and we found with the which presents challenges in terms of coronary access. And with the Evolute platform, almost in 30 to 35% of cases, the coronaries are either behind the skirt or behind the commissures, whereas with the Sapien valve, only 3 to 4% of the coronaries were behind the skirt. So which can be a challenge for coronary access. We saw that today in our live case where we couldn't even engage the coronary. And this was a registry that was presented at TCT a month ago, of a caveat registry, where they took patients with all different kinds of valves and looked at challenges with coronary access. And they found that Sapien 3 valve coronary access was achieved, selective coronary access was achieved in 89% of cases, and it was significantly better than all other valve types. Landing zone for redo TAVR, lifetime management, which depends on the neoskirt and how high the leaflets are located. And of course, when it comes to coronary access and redo TAVR, the short frames really are a winner. Here's an analysis which showed that it's a simulation analysis which shows that 27% of patients who undergo Sapien in Sapien may need leaflet modification for coronary challenges, compared with 91% of patients who undergo Sapien in a tall valve frame may need leaflet modification. This was a follow-up analysis by our fellow who then looked at the risk of sinus sequestration if you do TAVR in these patients with Sapien or Evolute valves. And again, the risk of sinus sequestration was significantly higher with the Evolute platform versus the Sapien platform. But again, these patients are there and they need to be treated. This was a 65-year-old patient with a failed 26 Evolute, and there was very high risk of coronary occlusion in this patient. We couldn't even engage the coronary selectively. So here we actually did the basilica to the left coronary leaflet, and then after a nice basilica cut, we deployed the valve at node 4 to node 5 with a good result. And here's a case of, we did a shortcut this was part of the trial, shortcut on an Evolute valve. We with both left and right coronary leaflet to get and then deploy the valve. And likewise, we've done the same basilica in a Sapien valve, although this is very rare to see challenging anatomy with Sapien, but at times you do encounter these anatomies. In terms of lifetime management, I think it's very important to implant the first valve right, so that we can manage the patient with one open heart surgery rather than 2 open heart surgeries in the lifetime. So to conclude, both Sapien and Evolute platforms demonstrate excellent clinical outcomes despite differences in hemodynamics, excellent valve durability, and ease of use. Clinical experience with Portico Navitor valve is limited in the US, but ease of deliverability, superior hemodynamics, large cell design, intraannular leaflets there, and make it a good landing zone for redo TAVR. And the short frame Sapien platform may offer advantage over the tall platforms in terms of deliverability, steerability, coronary access, landing zone for redo TAVR, and likely lower risk of surgical explantation in future. Thank you.
Thank you so much.